So let's talk about some of these, and we'll start with ER and PR. Here's a little, I put my picture up there, I'm not sure why, but I wrote this, Improving the Accuracy of Hormone Receptor Assays in Breast Cancer, an Unmet Medical Need. Why did we get the first ER test? It's a young audience here, so everyone will say, well, to predict whether a patient would benefit from tamoxifen treatment. And of course, that's not right. The ER test was introduced really in the late 60s and became commonplace in the early 70s, more than a decade before tamoxifen was discovered and approved. It wasn't developed for medical therapy of breast cancer. It was developed for surgical therapy of breast cancer. Women were being subjected to radical operations, bilateral oophorectomy, bilateral adrenalectomy, and even hypophysectomy to try to stem the progressive, painful, bony metastasis syndrome in women with advanced breast cancer. And these were not, laparoscopic, robotic-assisted operations. These were big laparotomies causing tremendous harm with blood transfusions. I mean, things you would never want to do to an advanced cancer patient. Suppress their immune system by giving them somebody else's blood and putting them through the stress of an operation only to find out they got no benefit at all. So we got this test, and some of you remember the name of it. Some call it the biochemical assay, or we call it the dextran charcoal assay, or the competitive ligand binding assay, designed to tell us which patients unlikely would benefit from this operation and spare them the harm of operating on them. And then in 1983, tamoxifen was introduced, and it became a medical therapy indicator, because surgical therapy obviously went completely out of practice when we had an anti-estrogen drug. And I think a lot of people thought, well, tamoxifen testing is great, and we got a wonderful test. But in the mid-90s, we switched to immunohistochemistry. Pathologists were thrilled. We had a personalized medicine test for breast cancer. We looked out under the slide. We made sure the invasive cancer were the cells that were expressing the nuclear receptor. And what an advance improvement it was over the ligand binding assay. Because if you were a medical oncologist in 1994, 95, 96, you were pulling your hair out. Because where was the femtomoles, estrogen receptor protein per milligram cytosolic protein data? You couldn't put a patient on a protocol without the femtomoles. And we were telling you positive and negative. And people were going, well, I can't put the patient on a protocol without telling me the femtomoles. And we said, we pathologists ain't going to be any more femtomoles. Why? Why did the biochemical test go away? Why did the slide-based test come in? Yes, most pathologists say because the slide-based test was better and we were making improvements. And of course, that's not true at all. Anybody know why? Why did we switch? Two reasons. Mammography and self-examination. We were also promoting women to examine their breasts and also to submit to screening mammography. And the size of the primary tumors get smaller and smaller and smaller and smaller. In 1968-69, when the test was first introduced, the average size of a newly diagnosed breast cancer in the US was 2.7 centimeters. Big tumors. Women were coming in late. And as we started to screen, they got smaller and smaller. And by 1990, it was down to under 2. By 2000, it was around 1.2. 2009, the thought is we're going under 1 centimeter to 0.9 for the average span of a newly diagnosed invasive breast cancer in American women. And as a pathologist, there's no way I can do lymphovascular invasion, lymphocytic response. Is there an extensive intraductal component? Is it got this or that Bloom-Richardson grade? And take a half a gram of it and submit it to make the biochemical assay. So in the end, it went away because the tumors got too small and no other reason. We never standardize it, and we have one of the worst tests out there that critically decides how women are going to be treated with breast cancer. I mean, if you ask, the typical woman who comes in with a newly diagnosed is first informed about the node status. And if the node status data is in, the next most important data determining treatment is estrogen receptor status. And we're doing a test that on a good day is probably 20 or 30% inaccurate on a good day. And why? Because there's no standardization and there's no common way we do it from place to place. Can we ever standardize it, make it better? Well, I hope so, and we have things in way. One thing we must talk about with these biomarker tests and all the cancers, but especially breast, are the pre-analytic factors. which is difficult for laboratories sometimes to control. But so many things happen to our specimen after it's removed from the patient, before it's tested, that determine what the test result is. If we don't control those, we're never going to get standardization. I can remember asking 25 years ago, Becton Dickinson, to make a specimen processing standardization for tissues like they did for blood vials. Let's have colored tubes and mandatory time recording of patient removal, immersion in fixative, destination, etc., and we never did it. So what happens is we are sometimes unaware of what some things can do. And fixation is one of the top ones. When we put a breast cancer in formaldehyde, the number of hours it is immersed causes a change in the number of nuclei that stain for the estrogen receptor antibodies. And as time goes on, number of antibody markings occurs more frequently, and we end up with increasing staining. And this is one study that demonstrated that.